Hello, my name is Ashley Bartel, and today I will be discussing the OB emergency postpartum hemorrhage through a case study. The learning objectives for this presentation is know how to assess and identify a PPH, know the medications used for PPH and the contraindications of those medications, be familiar with the interventions that may occur with a severe PPH, know what to look for postpartum after PPH has occurred, and identify how PPH may impact a mother and her family. A PPH being a postpartum hemorrhage, just for reference. So when we are healthcare providers, we are looking for risk factors for emergencies such as a PPH. However, it is important to keep in mind that postpartum hemorrhages can occur with little warning. Risk factors predict only 40% of the cases. So we'll discuss more of the risk factors during this case study. So case study, Luna Lovegood is a 32-year-old woman, G7L6. She presented to the labor and delivery unit stating her contractions started 55 minutes ago. She's having 4 and 10 contractions, 60 to 75 seconds long, palpating strong during contractions, soft at rest. She states she has fast labors. Her history indicates she's had PPH with 3 of her previous deliveries. Her vaginal exam done 10 minutes ago indicates she is 8 centimeters dilated, plus 2 station and fully effaced. So what is a PPH? What are Luna's risk factors for a PPH? And how should the nurse prepare for Luna's delivery? A PPH is a medical and obstetric emergency. It includes blood loss over 500 mils in a vaginal delivery and 1,000 mils in a C-section delivery. It occurs after the baby has been born, and it can be classified as early as late. Early is within the first 24 hours postpartum, and that's when most postpartum hemorrhages occur. Causes can be remembered using the 4T mnemonic, which is the tone, tissue, trauma, and thrombin. There's a table on page 744 of our textbook, table 19.1, which will go into more detail of this if you need further information. So the tone indicates the ability of the uterus to contract efficiently. If we think about the placental site, there are many open blood vessels. The uterus needs to contract down on these to prevent hemorrhaging. So risk factors that the uterus may not contract effectively are generally multiple gestation, rapid labor, prolonged labor, high priority, and oxytocin use. There is other causes such as fever, fibroids, prolonged rupture of membranes, and whatnot. Tissue, the most common cause is leftover placenta in the uterus, and other risk factors can be previous uterine surgery, high priority, and an atonic uterus. Trauma, this can indicate lacerations to the cervix, vagina, perineum, and C-section incisions. It also includes uterine rupture and inversion. And thrombin is any abnormalities with coagulation, which can be pre-existing or caused during pregnancy, history of coagulation abnormal causing illnesses, as well as fetal demise and antepartum hemorrhage. Luna's risk factors for a PPH is rapid labor and high parity, as well as a previous PPH times 3. This is a risk factor mainly because I don't know what her previous hemorrhages looked like or why she's had them, and she's had 3 of them, so it would get my spidey senses going. So when we prepare for Luna's delivery, we want to make sure there's an IV access with a saline lock going. If she's GBS positive, this will already be here. We want to obtain necessary blood work and cross-match. These are our coagulation studies in our CBC. The physician may not want them right away, but at least let lab know that this woman is here and that maybe have the lab, like the rec, written up in the meantime. And especially know where the PPH medications and IV fluids are. So ergot and hemabate are commonly left in the fridge, and so those are also really important to know. So Luna delivered a healthy baby boy weighing 3,444 grams. Immediately after delivery, Luna started to hemorrhage. So what does the healthcare provider do next? And what medications will Luna likely receive? So when we think about a PPH, we're going to follow the decision tree that is lined out by MORE-OB. This is more directed towards physicians, but there's things in here that nurses will be assisting with. So the first thing is getting help. We need all hands on deck to make sure this mom gets treatment fast and efficiently. We're going to be assessing her circulation, airway, and breathing. We're going to be getting those vital signs on her right away, making sure they're going. doing the fundal massage, making sure that that uterus is firm. The GP will perform assessments or bimanual assessments. We're going to get lab work if that wasn't already done, stat. We're going to prepare to administer fluids and medication, so that may include mixing up that oxytocin, and we're going to prepare to put a Foley in, and that's going to help allow the uterus to cramp down the way it needs to. Here is the decision tree, so you know what it looks like. So what medications will Luna likely receive? So she's going to routinely receive that 10 units of oxytocin IM in her leg. She'll likely get the oxytocin IV, and we're going to be monitoring for hyperstimulation. For all these medications, we're going to look at our own hospital policy to figure out how much. The misoprostol, which is usually given per rectum or buccally, the ergot, this can cause abdominal cramps, and it's contraindicated for individuals with hypertension. The hemabate, it's contraindicated or used with caution in the asthmatic population, can also cause abdominal cramps and diarrhea. And then the tranexamic acid. So other causes of bleeding in the PPH when it's not resolved with medication is going to be lacerations to the cervix or the vagina, or the coagulation disorder such as DIC. So Luna's bleeding has stopped. The physician noted there was no lacerations and the estimated blood loss at 1200 cc's. The fundus is firm and Luna is transferred to the maternity unit. So what assessments will the nurse continue to do, and what teaching should the nurse provide to Luna and her family? So we're going to keep doing the vital signs Q, 15 minutes for the first hour, 2 hours postpartum, and 6 hours postpartum. We can do it more frequently if we're concerned. We're going to be doing frequent fundus checks, making sure that fundus is firm, checking her flow, making sure she's not soaking through a pad in an hour, and her voiding status. We can measure it too if we're concerned that her bladder isn't emptying appropriately. The teaching we're going to teach Luna is how to check for her fundus, know when to let us know about her flow. If her clots are larger than a toonie, we would like to know signs and symptoms of infection, postpartum blues and depression, her contact information for her PH, for a public health nurse and the GP, as well as dietary counseling. She has lost a lot of blood, so iron supplements as per her physician will give her teaching about as well. Another thing to keep in mind is Luna's emotional well-being. So psychological and physical trauma during labor can directly impact mother-newborn attachment. Talk to the mother and family to reduce any anxiety or fear. PPH can cause anemia, leading to increased fatigue. It can make those first few days with baby quite difficult. So things to remember is PPH is the leading cause of morbidity and mortality in the mother. It is defined as more than 500 mils with a vaginal delivery and over 1,000 with a C-section. Early PPH is classified within the first 24 hours, late is anytime after that. And then more than 50% of maternal deaths occur in the first 24 hours, most frequently from bleeding. Oxytocin is currently on a global shortage, so we are not to premix, just a good note to know. And I'd like to thank you all for listening to my presentation. Here are my resources that I have used, as well as Moral B, which is a members only. Thank you and have a great day.